Él es médico consultante de la División de Gastroenterología y Hepatología del Departamento de Medicina Interna de la Clínica Mayo en Arizona. Es una persona sumamente reconocida en lo que es el estudio del eje cerebro-intestino y la utilidad de nuevos tratamientos en enfermedades autoinmunes o enfermedades que pueden llegar a ocasionar alteraciones a nivel intestinal. Adelante, doctor Pasricha.
Thank you. It's the end of the day, and I think you're all looking forward to your next beer or dinner or whatever it is. I am very happy to be here to give this talk, and I want to thank the organizers once again for the privilege of being here. My talk is called Autoimmune Gastrointestinal Dismotility. So before I start, let me ask you, have you ever seen a patient with autoimmune GI dysmotility? Raise your hands, please. Who has seen it? She doesn't know. 3 people. That's very good. That's 3 more than I expected. So we are off to a good start. And at the end, I will have a conversation with the 3 of you and the person who says she doesn't know, okay? But what I will talk about today, first give you some background, and it's not just about autoimmunity, because as you will see, part of being a clinician, particularly in this difficult field of neurogastroenterology, is always to be on the alert to connect the dots. And today's lecture is all about connecting the dots. And what are the implications for treatment after you make those connections? And then finally, some conclusions and take-home messages. So actually, there have been lots of papers and studies on autoimmunity and GI motility disorders. Constipation, gastroparesis, achalasia, the entire spectrum. However, it has been very difficult to show that those antibodies actually can cause the disease. At the same time, in the few studies that have looked at surgical specimens of the gut, whether it's from the small intestine, sometimes in the colon, in some patients there is clearly inflammation surrounding the myenteric plexus where the nerves and interstitial cells are. So it is very intriguing to know that there may be something going on that we can actually intervene. We are all very good at giving symptomatic treatments. A lot of them don't work. We're also very good, as this wonderful lecture I just listened to on complementary and alternative medicine, to try different things. But one of the things we haven't tried is to go back and see, is there an organic basis for many of these disorders that we call functional? Because if we find an organic basis, particularly an immunological or inflammatory basis, then we may be able to not only treat the patient for their symptoms, but modify the disease. But here is where we come to the fundamental problem. How do you define autoimmunity? Now, if you ask a rheumatologist or an immunologist, they will say the classical way is to show the presence of autoreactive T cells or autoantibodies, so the T cell or B cell, and show that these then can cause tissue damage and then show that you can transfer the disease to animal models using these antibodies or cells. That's the classical way. But such an approach is not practical for us in the area of neurogastroenterology because you don't have sufficient preliminary evidence to begin with. So today's talk is about showing you that we may have taken the first step to provide the preliminary evidence. And the rest is up to you to keep this work up and start looking for this in your patients, as I will show you. So how did we begin? The first question was how to define what an autoimmune marker is. Lots of studies that I've showed you said, well, any one autoimmune antibody. That's not acceptable, right? That's too nonspecific. If you do enough tests, there are good chances that you'll find at least one autoantibody. How about more than one antibody? That gets better, a little more specific. And then finally, how about the presence of a known classical rheumatological disorder? That's even better, but then that forces us to think that all these disorders have to be described. How do we define a new disorder? So perhaps a combination of number 2 and 3 would be a good start, and that's how we started. So you take a stand at it. It's not the final word, but you come up with a working definition, and then how do you provide preliminary validation that this definition is really accurate? First, examine the prevalence of that autoimmune marker in your population. Examine the association of that autoimmune marker with other inflammatory markers, with tissue damage, and involvement of other organs or systems that are known to be associated with autoimmune etiologies. And then finally, of course, the real proof is if you treat these patients with immunomodulators or drugs that dampen the immune system, what is their response? So this paper came out a couple of months ago in the American Journal of Gastroenterology, and I will summarize the findings for you. This has been in the works for almost 10 years, I would say 7 at least, and it has come to be known as the JAG-A study, J for joint hypermobility, A for autonomic dysfunction, G for GI dysfunction, and A for autoimmune markers. So our study population was the presence of unexplained GI symptoms, including pain, but they had to include more than one region of the gut. All these patients were seen in just one clinic, and that was my clinic, so there was no question of variability. And we took patients with the kind of patients you see in your neuro-GI practices. They have pain, they have problems with constipation or problems with diarrhea, nausea, bloating, all of that. And we excluded patients who had single organ symptomatology. For example, achalasia we did not include, or patients who had pure reflux symptoms. And then we also excluded other factors that could be responsible for the condition: uncontrolled diabetes, uncontrolled thyroid, inflammatory bowel disease, etc. And we had 2 cohorts in the study. One was a retrospective cohort of 300 patients. We examined that cohort, and then we did a sort of validation study in a prospective cohort. In both cohorts, and this was my practice, we did a bunch of serology tests looking for autoantibodies. We did whole gut transit studies. We did tilt table testing using, yes, intravenous catheters, intra-arterial catheters, and pharmacology to provoke changes in their blood pressure or heart rate. And we also did skin biopsies to look for evidence of small fiber nerve damage. In the prospective cohort, These patients were questioned with standard validated patient-reported outcome measures that covered GI symptoms, autonomic symptoms, joint hypermobility, pain, headache, migraine, and of course, our favorite, the Rome classification. So what was the definition that we used? To remind you, it was either a known diagnosis of autoimmune autoinflammatory disorder with at least one circulating autoantibody, or in the absence of a known rheumatological disorder, 2 or more antibodies in patients. Now let's get back to that series of questions that I asked. So first we took this definition and asked what is the prevalence of autoimmune markers as defined here in the population. And as I said, we had a retrospective cohort first, 300 patients, and their features are listed here. As you can guess, most of them were women, relatively young women. These presenting complaints are familiar with you. But they also had postural symptoms, dizziness, lightheadedness, and sometimes syncope. 77% of patients. And half of them complained of abnormal sweating. History of migraine and recurrent headaches was present in 74 patients. In this retrospective cohort, 40%, 120 patients, had or satisfied the definition of autoimmune markers. But more importantly, 70% of those who satisfied actually had a known autoimmune disorder diagnosed by a rheumatologist before they came to see me. In almost all of those cases, the rheumatologist did not feel that their disorder was contributing to their GI condition, and that was well controlled. We then looked at our prospective cohort for 133 patients, basically similar symptoms. I didn't show you the gut transit studies in the retrospective cohort, but here you can see whole gut transit studies, esophageal delay in a third, half of them had delayed gastric emptying, small bowel delay in about 10%, and slow transit of the colon 64%. 29% of these, slightly less than the retrospective cohort, satisfied the definition of autoimmune markers. And again, almost the exact same percentage had a known rheumatological disorder. And these were the most common autoimmune associations: Hashimoto's, Sjogren's, lupus, mixed connective tissue disorder, or undifferentiated connective disorder. And we did about 20 antibodies, or we screened for about at least 20 antibodies in these patients, but these are the top 5 or 6 antibodies that we found. The ones that were the most important, which have been the least well studied, were anti-ganglioside antibodies, the same that are associated with Landry-Guillain-Barré syndrome. So that was the prevalence. Then we wanted to examine the association of these autoimmune markers with other inflammatory markers. And to do this, we pooled the results, the objective tests, in both the prospective and the retrospective cohorts. So we looked at the classical inflammatory markers, C-reactive protein and SED rate, and those patients who had autoimmune markers had almost twice the prevalence of elevated C-reactive protein or sedimentation rate than those without the autoimmune markers. Then we looked for evidence of tissue damage, and one of the things I said we did was we did skin biopsies in many patients. And again, in those patients who had autoimmune markers, almost 20% of them had small fiber neuropathy on skin biopsies, which was twice that of patients without autoimmune markers. Highly significant results. And then we looked at involvements of other organs or systems that are more generally accepted to have autoimmune etiologies, particularly autonomic dysfunction. So this is the cardiac tilt table testing that we did. And again, almost 50% of patients with autoimmune markers had objective cardiovascular evidence of autonomic dysfunction, either postural orthostatic tachycardia syndrome, or POTS, or neurally mediated hypertension. And then finally, we looked at other associations. We did a lot of tests, and you can look up that paper. And HLA-DQ8, we didn't do a full HLA typing, but we were interested in DQ2 and DQ8 because of celiac disease, and we found that, again, the prevalence of HLA-DQ8 was much higher in patients with autoimmune markers, and we know that HLA-DQ8 is associated with a variety of autoimmune diseases. But the most important thing is, if you're suspecting autoimmune disease, you have to find out then whether they respond to immune modulation. And so we did a pilot study in a small group of patients. We took about 44 patients, but in the end we analyzed somewhere close to 39, or I would say actually 33 patients. And we gave them intravenous immunoglobulin. Again, these patients were given if they were suspected to have an underlying autoimmune disorder, and these features are given in this table here. We gave standard immunomodulation doses, 2 grams per kilogram body weight, and patients who had at least 3 monthly courses were included in the final analysis. So our primary outcome was an overall treatment effect on a scale of -7 to +7, and this was very much in the positive range compared, well, there was no comparison. This was not a placebo-controlled trial, and so this was an open-label trial. But the effect size was about 0.5 standard deviations, indicating at least a medium effect. And these were the secondary outcomes that we did. Again, standardized questionnaires, PAGI-SIM, which is a score for upper GI symptoms, PAGI-QL, which is the same but for quality of life, PAC-SIM, which is for constipation and lower abdominal symptoms, PAC-QL, quality of life, PFDI was pelvic floor distress scores, ECHART, was the dysphagia score, and COMPASS 31 is for autonomic dysfunction. All of these, compared to baseline, showed very significant improvements. Now again, not placebo-controlled, so we can't really say it works, but the effect size is still quite impressive. Now, it's not an easy treatment to give. As a gastroenterologist, I started giving IVIG. I had no idea what I was getting into. And it is not easy. For some reason, these patients are particularly at risk for complications. And you can see that the most important was headache. We know that headache is common with IVIG, but we didn't know that in this patient population it would be that prevalent. Some of these patients had to go to the emergency room. They were diagnosed to have aseptic meningitis. That was the main side effect that used to keep me up at night. The rest of the stuff is manageable. Okay, then we started looking at, okay, so we got some evidence of autoimmune markers. What are the factors that correlate with this? And we found that as far as patient attributes are concerned, patients who had joint hypermobility had almost twice the prevalence of autoimmune markers than those who didn't. And if you look at the other scores, the pelvic floor and the COMPASS 31, they can all be explained by the presence of joint hypermobility because these patients have higher prevalence of both pelvic floor problems as well as autonomic dysfunction. So what do we know about joint hypermobility? We know that it's associated with the GI dysfunction and autonomic dysfunction. It is part of the spectrum of disorders that we call Ehlers-Danlos syndrome. And when you use the strict criteria as laid down by the Ehlers-Danlos Society, it's called hypermobile ESD. But without using those criteria, it is called part of the hypermobility spectrum disorders, or HSD for short. You can diagnose joint hypermobility in one of two ways. One is a simple 5-part questionnaire that the patient can fill out, and the other is the Baton scale. How many of you are familiar with the Baton scale? Okay, at the end of this, we will go through the exercise. I want everybody to test themselves on the Baton, and I will bet you 100 Mexican dollars that at least 5% of this audience will have joint hypermobility. Don't get alarmed. It doesn't mean you're at risk for any of these disorders. That's generally the prevalence in the audience. And we use the 5-point score because it has many advantages over the Baton, but we actually, in my practice, end up using both. So when we looked at our cohort with joint hypermobility, you can see that across the board, their symptoms were worse. But I want to highlight 3 things. The GI burden is much higher, significantly higher. The autonomic burden is out of control. These are so dysautonomia by itself was present in 55% of patients with joint hypermobility as opposed to without. But on the right are the COMPASS scores. So you can see the healthy controls are somewhere in 10, and then we compare this to published literature, diabetic neuropathy, small fiber neuropathy, scleroderma, and then in our cohort with no joint hypermobility and those with joint hypermobility. And you can see they had, the ones with the joint hypermobility had the highest autonomic scores. Pain burden, looking at pain intensity, looking at pain interference, looking at the McGill pain questionnaire, and looking at the migraine scores, all much higher in joint hypermobility. So in conclusion, in patients with unexplained neuro-GI symptoms, autonomic dysfunction is common. Regardless of joint hypermobility, regardless of autoimmune markers, 2/3 or more of these patients had evidence of autonomic dysfunction. Joint hypermobility is also very common. Half of more of these patients may have it. And the prevalence of autoimmune markers is significant. About 1/3 have that definition, but importantly, 1/4, 25% of these patients or so will have a known rheumatological disorder. And joint hypermobility is particularly associated with autoimmune markers, nearly twice as many as those without joint hypermobility, more severe GI symptoms, more severe autonomic dysfunction, and more severe pain. So this is what we call the JAG-A syndrome. Not everybody has all 4 components, but it's convenient to remember that because it reminds you to start looking for it in your patients. Some may have just AGA, some may have GAG, some may have none of this. It's fine. Well, they all have GI dysfunction because they're seeing you, but they may not necessarily have any of the other 3. And this has led back to the connecting the dots. People often say, well, these are functional. You have no evidence of objective disease. If you look, you will find it. In fact, GI dysmotility is very often part of a peripheral neural triopathy, often goes hand in hand with autonomic dysfunction and somatosensory dysfunction, causing them to have pain. And of course, the enteric nervous system is the 3rd nervous system as well. Some of them may also have autoimmunity. I think the jury is still out. We need to have better studies, more controlled studies, and, I'm looking forward to the rest of the field either disproving this or corroborating it. Why did we do this? Because we want to go beyond just treating patients symptomatically. As I said this morning, I am sick and tired of telling patients or hearing from patients that they're sick and tired. I want to do something different. Or, if you don't want to do that, stick with the Rome approach. We classified 133 patients by Rome. We had 400 diagnoses. Pick one. The one you can't pick is the centrally mediated abdominal pain syndrome. Because according to the Rome authors, this is the cause of pain, unexplained pain. Not one of our patients met the criteria for that. So take-home lessons. Defining autoimmune disease and GI dysmotility is not particularly difficult, and you don't have to agonize over the choices of antibody. Just look for the history. But remember, do not ignore hypothyroidism. We often have these patients coming and say, history of hypothyroidism, well controlled on Synthroid. Look deeper. Most of them will have a history of Hashimoto's. That's your autoimmune disease. But we ignore it. A lot of these patients will have dry mouth, dry eyes, Sika syndrome. They may well have Sjogren's. We attribute that to drugs, or I don't know, you got dry mouth syndrome. And that's another functional disorder. But look for, I do a lot, I do not just antibodies. I do submandibular gland biopsies in these patients. Autonomic dysfunction is extremely common in your patients. All you have to do is ask simple questions. Do you get dizzy when you stand up? Does your heart rate go fast? And now a lot of these patients have smart watches and they can show you that. Ask them about sweating. A lot of them will tell you they sweat at night, or it's too cold for them, or it's too hot for them. You say, that's your problem. It's part of your many other problems. And look for joint hypermobility in all your patients. You'll be surprised about what you will learn. Okay, here's the baton.